Okay, we'll make a start then. Good afternoon. My name's Tom Farden. I'm chair of Grand Rounds today, where we have a joint presentation from the Medicine for the Elderly Department and the Neurology Department. We've got three speakers today: Sean McCauley, who's an ST75 in MFE, and Esther Samler, who's an ST76 in Neurology, and then Catherine Young, who's a Parkinson specialist nurse. I'm getting the nod. Excellent. A few parish notices, not very many this week, but researchers at Dundee University have discovered a new compound which could treat malaria while protecting people from the disease and preventing its spread, all in a single dose. If you wonder why I have to have crib notes for this, it's because the drug is called DDD-107498. Just trips off the tongue. And it's been developed by the Drug Discovery Unit and the Medicines for Malaria Venture. Scientists say it's exciting. And could work well against parasites resistant to current treatments. Details have been published in Nature. A quote says, DDD-107498 is an exciting compound since it holds the promise to not only treat but also protect these vulnerable populations. The School of Medicine's Dr. Shihab Kagali and the Technology and Innovation in Learning team, TILT, have been shortlisted for a Herald Higher Education Award. The team are nominated for the Innovation Technology Excellence Award for their work on enhancing in-class team-based learning using mobile-friendly technology. And here is an example of some team-based learning happening in this very room with some mobile technology. The University of Dundee is also shortlisted for the Outstanding Employer Engagement and Campaign of the Year. The winners will be announced on the 16th of July at a ceremony in Glasgow. And next week is the ASME conference, which is the Medical Education Conference that's happening in Edinburgh this year. And I think we have something ludicrous like about 35 different posters to present at that meeting. So the Medical Education Department is certainly being prolific at the moment. And the University of Dundee, in partnership with the British Society for Antimicrobial Chemotherapy and FutureLearn, have developed a free online course, Antimicrobial Stewardship, Managing Antibiotic Resistance Certificate. Designed for healthcare professionals, this free 6-week course informs and empowers individuals to provide safe, high-quality antibiotic use, and it starts on the 28th of September. Okay. And I'll hand over now, I think, to Sean first, who's going to talk to us about the shaking palsy. Is that you? No. That's Esther's. That one's you. There you go.
Thanks very much, Tom. Thanks for the warm welcome. So just a wee bit of overview. So I'm going to speak a wee bit about James Parkinson and how understanding of Parkinson's disease has evolved. Catherine's going to come on and speak about the PD specialist nurse and their role and describe a couple of case histories. And then Esther's going to speak about Parkinson plus syndromes and some of the genetics involved with Parkinson's disease. So I've called the talk Rat Trap and So Much More, and we'll come on to that in the second half of my talk. But I'm going to start off with a wee bit about James Parkinson, because doing research into him this week, I've realised that I didn't know too much about him. So who was Parkinson? Well, if you do Google images, these are some of the things that might come up. In the top right-hand corner, there's Michael Parkinson, who anybody that's grown up with British TV will realise is one of the most popular chat show hosts we've had. The bottom three are all celebrities who have either had Parkinson's disease or some variant thereof. And the photograph in the middle commonly gets mistaken for James Parkinson, but actually, look at the wee point, I think. He actually died in 1824, so that was 2 years before the first photograph was taken. He was born in Hoxton, which is a village in Middlesex, in 1755. He was the son of a surgeon, the oldest of 3 children. Hoxton's now been incorporated into London, and it's in the borough of Hackney, I believe. He had 8 children, 2 of whom didn't survive to adulthood. As well as his contributions to medicine, he had an interest in politics, and he was an outspoken critic of the Pitt government. He had very socialist views. And around about that time, Europe was in a bit of chaos. The French Revolution was happening around about that time. So in order to protect himself, he wrote under the pseudonym Old Hubbard and distributed pamphlets with a political nature. He was also questioned about the attempted or supposed attempted assassination of King George III, although I think that was all shown to be a bit of a myth in the end. In later years, he developed an interest in paleontology, and he was one of the founding members of the British Geology Society. And on the right-hand side, You'll get pictures of fossils from one of his books, and on the left-hand side of the screen. The right-hand side, picture B, is a fossil from the marine in the period of the dinosaurs that was named after him. So he died in 1824, just a couple of hundred yards away from the house that he was born in. He worshipped at the same church all his life, and for that reason there's a plaque now in it. There's a plaque also at the house in 1 Hoxton Square. On the 11th of April every year we celebrate World Parkinson's Day, which was the date of his birth. And there's also a week in April for Parkinson's Awareness Week. So the thing that made him famous was this essay of the shaken palsy. And it was basically a case series of 6 patients, which he described having this shaken palsy, or paralysis agitans as it was called in Latin. A couple of key things. He distinguished between tremors at rest and those in motion, and he also described the classic stoop that you get with Parkinson's disease. But he did, however, predict that the primary cause was a spinal cord lesion, and he also said that the senses and intellect were left unaffected, so he didn't get it 100% right. Putting that into context of where Parkinson comes into the development of Parkinson's disease, as you can see, 1817 he wrote the essay on shaken palsy, and in the 1870s the condition was named after him by Charcot. Before him, 175 AD, Galen was the first Western physician to describe the shaken palsy. But if you go through ancient times, there's other descriptions in various medicines around the world, Chinese, Indian, etc. And one of the oldest ones is Campafata from an old Indian system of healthcare. Following Parkinson's death, there was further discoveries, some of which might be considered more influential in the development of Parkinson's disease. But I think the key to why it was named after him was because neurology as a specialty was forming in the period immediately after his death, and I think this was seen as one of the key contributions to it. So, 1912, Louis discovered these inclusion bodies spread about the brain, not particularly in the basal ganglia, but more in the cortical parietal regions. And 7 years later, Tretyakov, a Russian researcher, also found them, and he named them after Louis. In 1957, a Swedish scientist called Arvid Carlsson demonstrated dopamine was a neurotransmitter and found in high levels in the basal ganglia. Prior to that, it was thought just to be a precursor of noradrenaline. In the 1960s, in autopsies of PD patients, there was low levels of dopamine detected, and that prompted, in the 1960s, several trials looking at whether or not dopamine could be used to treat patients with Parkinson's disease. The most successful trial, and the trial that really established dopamine, or levodopa, as the treatment of choice for Parkinson's disease, was in 1968. And during this trial, Kotzias, who was a Greek doctor who moved to America, he demonstrated that if you started with low doses and built it up gradually, the patients were able to tolerate the side effects long enough to get to a therapeutic level so that you could demonstrate a benefit. In 1969, Molly Jenkins founded the Parkinson's Disease Society, which is now called Parkinson's UK. The American equivalent was founded in 1957. In 1973, a novel was published by a British neurologist who had previously migrated to the USA, called Oliver Sacks. This is called Awakenings, and basically it was subsequently made into a film. Basically, there was a pandemic of flu in the 1918s to mid-1920s, which left people in a highly catonic state. It was called encephalitis lethargica. And Sacks described cases of patients that he treated with levodopa, which was this new wonder drug at the time, and showed that the patients moved from a catatonic state to a progressively more mobile one. There are critics of his work, and it could be best described as quasi-experimental work. Moving on from him, in 1983, MPTP was found to have caused symptoms in heroin abusers. This fueled the debate as to whether or not it was an environmental cause for Parkinson's disease. In 1997, a single gene mutation in the DNA of alpha-synuclein gene was discovered. And again, this swung it back more to a debate as to whether or not it was genetic. In 2000, the Michael J. Fox Foundation was formed, and since its inception, it's raised over $90 million for research into Parkinson's disease. So moving on to the second part of the talk, which is my clinical approach to Parkinson's disease. And this is the reason why I've called it rat trapping so much more. At medical school, you're inundated with tons of information, having to learn all the different systems, all the different syndromes within the systems, and I found mnemonics were quite a simple way of trying to remember the cardinal features. Obviously, bradykinesia doesn't fit in quite as well, so I used to call it akinesia. And some people in the very late stages do become essentially akinesic, but mostly it's bradykinesia. But as I started training and got particularly into MFE, I noticed that Parkinson's disease was much more complex. You had non-motor symptoms, particularly affecting GI system. You get postural hypertension, you get neuropsychiatric manifestations. There's depression, social isolation. There's an impact on care, so it's much, much more complex. And also discovered that other than just idiopathic Parkinson's disease, there was this wide umbrella term called Parkinsonism. And there's lots of different causes for Parkinsonism, including vascular Parkinsonism, the Parkinson plus syndromes, and genetic Parkinsonism, which Esther's going to talk about in a wee bit. And that one gene that was discovered in 1997, since then there's been dozens more discovered. And putting them into the cell biology, it can get rather complicated. But you will recognise some things which I highlighted, which is the dopamine transporter, the interaction with MPTP, and the alpha-synuclein gene. And I'm not even going to attempt to explain that one, I'll leave that to Esther. But that's just an example of how complicated the whole thing can get. So in an attempt to simplify how we deal with Parkinson's patients, we divide them into motor symptoms and non-motor symptoms. So the motor symptoms are the trap ones, as we discussed above. They also get loss of facial expression, difficulty with their handwriting, difficulty with fine motor movements, difficulty initiating movement, periods of freezing. And as the disease progresses, they tend to get this on-off phenomena, and they tend to get more side effects from their medication and get dyskinesias. In terms of non-motor symptoms, depression is often the most common psychiatric condition linked to Parkinson's disease, and it often precedes the diagnosis by 10 to 20 years. You may remember that Robin Williams was known to be depressed shortly before he died, and he had recently been diagnosed with Parkinson's disease. And there's also a suggestion that he possibly had Lewy body dementia. The other things that we tend to ask about are bowel, bladder, orthostatic hypotension, problems with sleep, etc. There's a non-motor symptoms questionnaire that, depending on the locality, either the patient will fill in before they come to clinic, or one of the Parkinson's nurses will go through with them as well. And moving on to management of PD, I'm not going to talk about the specific drugs because we don't really have time to go through them all, but really what we're aiming to achieve is good motor control and improve the quality of life. All the buzzwords for geriatric medicine: we want to promote independence, autonomy, we want patient-centred care, and I think it's really important in Parkinson's disease that it is, because what I've learned doing the clinics again this past 6 months is that every patient's needs are different, their medication cocktails are different. You need to be very careful whenever you come into hospital and make sure that you get the prescription right. And of course we've got multidisciplinary input from the physios, OTs, maybe not so much at the early stage, but later as the disease progresses, and we may need to ask speech and language to get involved, and psychiatry of old age. And as they're approaching the terminal stages, or before they enter the terminal stages, one of the Parkinson nurses will normally go through anticipated care plans with them so that they can make decisions about how they would like to end their life, as opposed to having those decisions made for them when they can no longer communicate them. Parkinson's disease. Early on in Parkinson's disease, the control is quite good because the threshold response is quite low and the threshold for dyskinesia is quite high, so you've got quite a large therapeutic window. As the disease progresses, however, this therapeutic window gets lower and you tend to get more dyskinesia and more time in the off period. And at the very advanced stage of PD, most of the on times consistently associated with dyskinesia. So I think whenever they get to this, throughout the whole of their disease, but particularly when they get to this stage, small changes to medication can make a big difference. So my general rule of thumb is primum non nocere. I hope I said it right for anybody that speaks Latin, but that's a founding principle of medicine, which is first do no harm. But if I'm going to make any changes to the medications, I tend to make them small and slowly. Things that we wish to avoid whenever we're managing patients, I've divided it up into community and into hospital, but as you can see, there's probably going to be a bit of crossover. So generally speaking, we want to keep the motor symptoms as well controlled as possible, avoid fluctuations. We want to avoid dyskinesia. We want to avoid patients becoming socially isolated as a result of either their depression or their inability to move. We want to avoid the dopamine dysregulation syndrome and impulse control disorders, which I think Esther's going to speak a wee bit more about later. We want to try and avoid or treat depression and also try and treat the hallucinations. Again, coming back to the patient-centred viewpoint, a lot of Parkinson's patients have hallucinations, and they're able to rationalise them in their head. They're able to realise that they're seeing them, but they're not actually there. And for those people that they're probably not distressing, therefore, in such a case, you'd be, and particularly if the motor symptoms were difficult to control and the most important thing to them, you would probably avoid dropping down any of their levodopa or other medications. In the in-hospital period, we want to avoid prolonged off periods, so it's really important that we get the medication right. We want to avoid drug errors, we want to avoid patients getting drugs that may exacerbate their condition. Neuroleptic malignant-like syndrome is a rare complication caused by either completely stopping the medication or massive tapering down of the dose. It's rare, but it's potentially fatal, and we want to avoid that as well. All these things will lead to delirium and increase the likelihood of falls, leading to prolonged admissions and more likelihood of getting a hospital-acquired infection or having to be catheterised and get a hospital-acquired infection. So it's a bit of a vicious cycle that can develop if you don't get on board of the Parkinson's patient early into their admission. But thankfully help's at hand. We stole, I think is the best word, a sticker from Fife, which can go onto the Cardexes, which basically, I think everybody knows the medications that you shouldn't prescribe, but I suppose for a very junior doctor, for the middle of the night, for making a quick prescription of something that you don't know, you might not know their full case history. It's important to have these stickers on the Cardexes to make sure that there's no mistakes made. There's also a very small yellow bit in the sticker which says get on time, just a reminder that the patient should get the right medications at the right time and not necessarily what fits comfortably into the drug round. If you need a point of contact, there's PD nurses for each region, and Catherine will go into that in a bit more detail. There's also specialists within the MFE, so Deepa Simakatis and Derek Sutherland are for Dundee, James Shaw, Greg Cox for Angus, and Dirk Habik for Perth. We've got Esther and some of her colleagues from neurology as well as points of advice. And we've also got special pharmacists, so we've got Karen Loudon and Fiona Kelly. Unfortunately, neither of them could make it today because they're on annual leave. Coming soon, we've got the Tayside nil by mouth policy, and that should be ready in September. Some of you may remember that we had this before, but we're unhappy with certain aspects of it, so we've brought it off the formulary and we're making modifications to the minute, and it should be ready for release in September. How are we doing for time? Oh, very quickly. No talk about Parkinson's be complete without speaking about the DAT scan. So if you look at the DAT scan, the top two pictures is obviously a normal brain, and the next two are somebody in Parkinson's. The first of which is somebody pre-treatment of levodopa, and the second one with post-levodopa treatment. The thing about DAT scans is they're probably over requested. Clinically, if it's Parkinson's disease, that's the most sensitive indicator. Where DAT scans are useful is for very early Parkinson's disease, where they've only really got tremor, and it's hard to differentiate between that and benign essential tremor. There are, if you're thinking about some of the Parkinson Plus syndromes, you might want to think about other investigations like CTs, MRIs, etc. It's produced by GE Healthcare. It's a SPECT scan, and radioactive iodine is given as the tracer. An hour beforehand, you have to take oral iodine tablets to protect the thyroid. It's been in use in Europe since about 2000, and it only got approval in the USA 4 years ago. And just kind of before we go on to Catherine, just really, I read this abstract from 18 months ago whenever I had the clinical genetics talk, do you remember? And I was fascinated by that talk, and occasionally now and again you get something in the news, and this is the British Isles Project, people of the British Isles Project, which indicates the different gene pools within the UK, and I was interested to note that there was two distinct correlations between Northern Ireland and Scotland, and the first of which is the green triangles, if you see, extending from Northern Ireland up into the west coast of Scotland, and that was believed to be in relation to the time of Dalriada, the kingdom that extended from Northern Ireland into the west of Scotland. And the second one was from the 1600s, the yellow circles, which was the plantation of Ulster. So I think genetics are brilliant, and they certainly will be the future of gene therapies and developing drugs to modify the course of the disease. But I think in order to put them into context, you need to know a wee bit about the history of disease, the history of the people you're treating. Thanks very much. I'll just hand over to Catherine. This one?
No.
I think yours.
That's me.
Yeah. Do you want that? Just press that to go across, or just use the arrow keys?
Thank you. Good afternoon, everybody. My name's Catherine. I have the grand title of Clinical Nurse Specialist in Movement Disorders, which was the in vogue title when I was appointed in 1999. But principally, I'm the Parkinson's nurse in Nine Wells, and I'm based in the neurology department. And I've been around for 16 years last week. I can't believe it. Okay. I'm pleased to say there are actually 3 of us across the Tayside region who are Parkinson's nurse specialists. Myself, who covers Nine Wells Hospital, Lorna Gillis, who's based in Perth Royal Infirmary, and also Linda Patterson, who's based at Stracathro Hospital. So there should never be a point, certainly within Monday to Friday 9 till 5, that you can't access us for advice regarding any patients. We may not always be familiar with the patients that you're looking after, should they be inpatients or community patients, but we would certainly do our best to help advise and give some background information where possible. We have a multifaceted role, really, and we're very, very privileged to be able to spend or dedicate time to people with Parkinson's. I can't imagine to describe how much I've learned over the years that I've been in the post, and I continue to learn constantly, because as Sean says, the patients are so different between their complex medications, their attitude to life, their diagnosis, their family dynamics, and where in life they're actually diagnosed as well. But principally, our role with the community patients would be to maintain the stability of their Parkinson's symptoms. So that's pretty much seeing them both in outpatient clinics, provide a telephone advice line so that patients have access to the nurse specialist at times between clinic appointments, and sometimes it's just a reassuring voice at the end of the line. My main role is monitoring and reviewing the symptoms. Once a person has a diagnosis, they're referred to me from the neurologists, and I would meet them for the first occasion, would discuss their diagnosis, and then would develop a relationship which lasts throughout the remainder of their life. And I'm constantly monitoring and reviewing their symptoms and medication. Really, the idea is very much prompt interventions at time of symptom progression. I want patients to get in touch with me, as do my colleagues, to tell me when they think things are maybe going wrong. And sometimes they're fine, they just need a bit of reassurance. Other times it's been going on for a while and they need a bit of support, and we need to review their medications. Generally, now that we're all nurse prescribers, we can give advice to our GP colleagues as well as other medical professionals, and we can adjust medications ourselves. But Parkinson's management is very much a team approach. So we would always make sure that we're discussing with the general practitioners, we're speaking to their specialist consultants and the other professionals that are involved, and appropriately adjust their medication. It isn't always that the medication needs adjusted. It could be that they've got financial worries. It could be a number of things that can be easily remedied without making any changes to their drugs. The overall thing, certainly when I came into post, was apparently previous to that there had been a number of admissions to the neurology ward, and people with Parkinson's would be in hospital for weeks on end because they were so complex. Being in hospital took them right out of their comfort zone. It wasn't the best place to observe them. My role is very much to prevent admission to hospital, certainly for the reasons of managing Parkinson's. And I'm lucky, as are my colleagues, that we're able to go out and visit people at home at times of crisis. And being there and able to promptly intervene can make such a difference. Obviously, if there's an acute infection of some description or some other health problem, admission to hospital is necessary. timely referral to the allied health professionals, social work and the voluntary sector's organisations. But to be honest, for a long, long time, most people with Parkinson's will have slowly developing symptoms, and they'll only be involved with their specialist medical team at regular reviews at clinics and their Parkinson's nurse if they've access to one. I have to say there is one area, unfortunately, MFE and Dundee don't have access to a Parkinson's nurse, but we're hoping to rectify that in due course. Okay, I thought I'd do a case just to highlight a bit of my role. John's a 62-year-old chap who was diagnosed around 4 years ago with Parkinson's. He had very early symptoms of some tremor, slight bradykinesia and rigidity, was generally coping quite well and didn't need medication initiated for some time. However, as his symptoms developed and life became a bit more difficult, gradually ropinirole was introduced, and then that was taken to a certain level. When that wasn't managing his symptoms completely, Madapar was introduced. And everything was going relatively well. However, around 4 months ago, I had a phone call from his wife, very concerned that, mainly about reports of hypersexuality, his libido was much higher than his wife was prepared to cope with. It's not an unusual thing, and usually when you tell patients who are starting on dopaminergic medication that this is potentially one of the side effects, they say, "Whoopee, when will it happen?" But unfortunately, when it does happen, it's not in the loving manner that they are accustomed to. It tends to be more of a demand. However, when I went out to see John, it transpired that he also had end of dose wearing off, so his symptoms were certainly fluctuating. He had episodes of freezing, difficulty with gait initiation, and he was unsteady at times. He had always been a very keen DIYer and had done lots and lots of things around the house, and was absolutely appalled when he told me that he'd actually hurt his back by having spent all night, and I mean all night, on the bathroom floor kneeling, trying to sort the screw on the toilet seat. And I said, "What on earth did you do that for? What were you in there all night?" "Well, the wife was in her bed, so she couldn't interrupt me, and I always must get this job done. I must get it done." And I said, "Is that not a little bit obsessional?" "No, that's just how I've always been, but it takes a long time now because my fingers don't work well, I get stuck, this, that and the other." But as we discussed it, his wife said, "No, he is getting more obsessional about things. He must do certain things." So that made us think, what's going on? Has he got some side effects, obviously, to these medications? We have problems with impulse control disorder, and certainly since these drugs have been used worldwide, there are more and more reports coming out of odd behaviours coming from patients. And unfortunately for some, the hypersexuality side of it is very complex. It's a very private area of someone's relationship. And it can take them time and encouragement to actually talk about that. And that's really where the nurse's role comes in, because we get to know these patients so well for them to impart that kind of information. But there's also the chance that they could be gambling. And it might be that they've accustomed to putting on a bet on the horses on a Saturday, but actually it's now every day. That they're borrowing money that they can't possibly afford to repay, and there has been instances of people becoming bankrupt and their marriages breaking up, all sorts of issues because of these side effects of these drugs. And it's the tendency that the reward system, it becomes so mixed up with the medication that we're giving them, with the Parkinson's as well, that one patient describes having a great reward. It's fantastic, the thrill of pressing the buy button. "I've purchased this item off the internet. I don't need it, don't want it, don't even look forward to it coming in the post. But pinging that button is fantastic." So, with counselling, and they're warned about this as they go on these medications, but with counselling, we discuss all of this with them on a very regular basis and begin to reduce those medications. So basically that's what happened with John. We decreased his ropinirole and gradually increased his Madapar. And I'm pleased to say that with monitoring of his response by a weekly telephone call and checking for side effects, which we were dependent on his wife a lot of the time because he didn't quite have the insight we'd hoped, gradually continuing to decrease the ropinirole and, as necessary, increase the Madapar. And he's also been referred to physiotherapy and occupational therapy. And he's doing well at the moment. Within patients, recently been very involved with planned admissions, which has been great, participating in the pre-assessment to ensure that Parkinson's management remains stable. I have a gentleman waiting to come in for a nephrectomy who's had Parkinson's for 30 years. And you wouldn't, by the look of him in his wheelchair, think that he's possibly going to be able to undergo this operation, but he's determined. And so far, he's been medically cleared fit for it. So quite a complex medication regime. Must ensure it's absolutely essential that the medication is prescribed at the times and at the frequency taken at home. It can be so disruptive to the patient's management and also creates a great deal of anxiety for them and their carers. And the amount of times that I hear relatives saying, I've tried to explain to the staff in the ward that my husband, my wife ought to have this medication at these times. I've given them the sheet and it's still on ward round times. We've got to get into our heads that these patients need dopaminergic medication to give them the fuel to get out of bed, to get moving, to carry on their lives. And if you don't keep topping that up, they won't recover well. In fact, we risk causing them much, much major problems. I give advice regarding nil-by-mouth plans, and as Sean also mentioned, the last thing we want to see is neuroleptic malignant-like syndrome happening to patients. I've seen it once in a situation where a gentleman was in an episode of delirium and was absolutely refusing all manner of medication, and we had to very promptly get medication into him subcutaneously to try and bring him back to us. Unfortunately, it worked. So it's very much on the staff, education from the nurse's perspective to explain why the medication has to be administered as it is at home. The Parkinson's nurses know these patients very well, and we can assist with background information. As Sean said, the guidelines for nil by mouth are currently under review, and they will be very helpful to everybody when they finally come out. From A&E, from Ward 15 or AMU, when admitted, it's essential that people recognise Parkinson's is important. Obviously, and I've been there, the acute admission, the illness that's brought that individual in is primary, but we've also got to think about the Parkinson's to maintain that. And one of the things that we maybe need to look at and will be in the guidelines is that if we've got a patient who comes into AMU or A&E and they cannot take their oral medication, that's when we should be looking at putting on a patch. Get the transdermal patch on so that we're not risking them going into off episodes and struggling. And then we can look at other methods of getting their medication into them. So my role really is supporting changes in medication, keeping an eye on these patients, advising and being part of the team. It kind of maybe sounds as though I come in as the big bad Parkinson's nurse, but that's not how I want to be seen. I want to be seen as being helpful. Review and monitor the progress and participate in the discharge planning. And again, it's back to review with a Parkinson's nurse once they're discharged home. One of my inpatients, who I've called Albert, is 65 years old. He's had PD for 6 years. Unfortunately, he's very bradykinetic, very, very slow. He was a plumber by trade and had to give up work, just could not continue his work at all. Symptoms of his Parkinson's are very advanced, much, much quicker than you would normally expect. In addition to his motor problems, he's poor balance, swallowing and speech problems, urinary issues, but he has no cognitive problems. He's completely intact. Sadly, he was admitted with aspiration pneumonia fairly recently, and his usual medication regime was, as stated, Madapar 4 times daily. Hallucinations had been experienced in the past, and so dopamine agonists weren't good for him. However, when he came in, it was a question of, well, what do we do with this chap? He can't take medication orally. He's had a problem with dopamine agonist, which is what the transdermal reticotine patch is. What do we do? The kindest thing to do is to put on a patch, and that was what was decided as a first-line treatment. As time went on over the next couple of days and he wasn't recovering as quickly as anticipated, an nasogastric tube was passed, and then oral dispersible Madapar could be administered through the tube, and the patch was discontinued. Took a long time. He's been in hospital for many, many weeks, and he's gradually gone back to Madapar capsules, onto his usual regime, but he needed time to recover and attain his symptom stability. What I would say is that I sometimes get calls from various parts of the hospital, maybe particularly orthopaedics, when someone's come in, had a hip replacement, and they're not maybe being as active as they were expected to be. And there's always the thought of, could we up their medication and get them going a bit faster? And my answer to that is no. No, let's keep everything the same and give them a chance. Fair enough, when they go home, and they've been home for a wee while, if things are still not coming on the way it should be, then yes, we'll review the medication at that point. So thank you for your attention. Basically, I would say, as it says, if in doubt, phone switchboard. You'll get a Parkinson's nurse somewhere in the hospital, or for advice, and we'll do our best to help you as much as we can. Thank you. And it's now Esther.
So I hope this is not too much Parkinson's disease for you all. So I'm from the neurology department, and in neurology we also look after Parkinson's disease patients, usually the younger ones, usually the weird and wonderful ones, and possible the ones with a family history. So this is a poster from the Michael J. Fox organization. It's brilliant if really high-profile people suffer from diseases because they pour money into research, and that is really, really important with especially neurodegenerative diseases such as Parkinson's disease. So basically on this poster, I don't know, does this work? Yeah. So on this poster, basically like Parkinson's disease is really, really common. There are symptoms such as the symptoms like the non-motor symptoms reported by Sean that are really not very well known. It is really quite fascinating or like quite shocking that until a patient really develops motor symptoms, 60 to 80% of the dopaminergic neurons in the midbrain need to have died. So basically something is going on for years and years before someone actually becomes symptomatic and obviously Parkinsonian and basically allows to make a diagnosis. And what is also quite shocking is that 1967 was the time when levodopa came into play, and this is still our most powerful medication to date. So basically, like, here in Tayside, we have about 1,000 patients with Parkinson's disease. In Scotland, about 10,000 patients. We do know that some cases are familial, but most of the time it is not really quite known what is causing the disease, but there's an intricate interplay between genetics and environment, and really only the fewest cases are caused by Mendelian inheritance. This is similar picture as Sean has shown. So basically, this was when James Parkinson described the first cases, and then, here I can't avoid saying it. So Friedrich Levi is a German neurologist who immigrated to the States, and somehow there's a big drive in German neurology to basically repatriate him, and so Lewy body dementia is Levi body dementia and Levi body. So if you refer patients to me, please, that's how it should be done. And then basically, so we are here in the 1990s, we are moving into the genetic era, and at the moment it's really like biochemistry to really dissect signaling pathways and trying to understand what these genes do, how the perturbation of these gene products, proteins cause Parkinson's disease, and how we can possibly intervene and how we can possibly detect Parkinson's disease earlier before 60 to 80% of brain cells are dead. So Parkinsonism is a very heterogeneous group of neurological symptoms. I'm not going to speak about symptomatic Parkinson's disease. Pretty much 102 million things on this earth can cause symptoms suggestive of or looking like Parkinson's disease. Most importantly, drugs, toxins, small vessel disease, like structural abnormalities such as hydrocephalus. But this is not really what we are talking about. Sean has been talking about idioparkinson's disease, and I thought I focus my talk on PD+, so Parkinson's disease plus syndromes, and familial Parkinson's disease and genes. So basically, Parkinson plus syndromes is everything that looks like Parkinson's disease, but has also like atypical features, or everything that is called a red flag for the diagnosis of Parkinson's disease. So early dementia, early hallucinations, prominent early dysautonomia, then supranuclear gaze palsy, so where patients can't look upwards, so ataxia, and poor levodopa response, and often no family history. So part of the Parkinson disease plus syndromes is multisystem atrophy, dementia with Lewy bodies. It's really like a little bit arbitrary. Usually like Parkinson's disease patients with long disease progression will eventually develop dementia, but Lewy body dementia is really like where the dementia is very early on in disease progress. Then progressive supranuclear palsy, corticobasal degeneration, and if you want to, you can also like maybe like put these juvenile onset pallidopyramidal syndromes, so Parkinsonian syndromes with lots of other symptoms into this category, and then say do differ by neuropathology, but usually that is not very helpful in the early stages of diagnosis. This is just one table to somehow try to show you symptoms or signs that might help to differentiate the different symptoms. The really age of onset is not too helpful to differentiate between Parkinson's disease, multisystem atrophy, progressive supranuclear palsy, or corticobasal degeneration. Maybe the family history, it's more likely to have a positive family history in Parkinson's disease, not so in the other Parkinson plus syndromes. Usually Parkinson's disease, idiopathic Parkinson's disease is asymmetric in onset, whereas PSP is symmetric. Then one really prominent feature which also like helps to make the diagnosis is upward gaze impairment. So basically like you ask the patient, please look up, and they can't do this, but when you do doll's eye maneuver, it is clear that it's not ophthalmoparesis, but it's a supranuclear problem. Then dementia, usually in Parkinson's disease late, and early and prominent in corticobasal degeneration, and frontal type dementia in PSP. Then tremor, like is often seen in Parkinson's disease, uncommon in PSP, and a little bit different, not the usual pill rolling tremor in corticobasal degeneration. Then a DAT scan really doesn't help you at all, because a DAT scan is abnormal in all of these diseases. Then olfaction, loss of sense of smell is often seen in Parkinson's disease, often before the onset of motor symptoms, but is usually normal in these other Parkinson's disease plus symptoms. Then autonomic failure is usually seen in Parkinson's disease late, but early, for example, in multisystem atrophy, and then there are these other symptoms that help to differentiate. But what is also quite important is, which I didn't really mention here, is levodopa response. So usually a very, very good and prolonged levodopa response in idiopathic Parkinson's disease, but not so like possibly at the beginning you have a little bit of a response to levodopa, but then like this response is not really prolonged and sustained. So coming to familial Parkinson's disease, so this is like a very famous British neurologist, William Gowers. He already noted a positive family history in 15% of patients in 1902. This is probably a little bit of over-reporting. So this is him with all his colleagues at Queen Square, the National Hospital of Neurology in London. It took a little bit of a while, so although it was recognized that there seemed to be like a positive family history in some cases of Parkinson's disease, it took quite a while until really like a quite convincing pedigree of an autosomal dominant family with Parkinson's disease was described in the literature. So actually like two kindreds, but it then turned out that these two families were related. They were from Italy, and they were really quite related going back to the 1700s something. So, and then again, like it took a few more years where then first the locus was linked and then identified as alpha-synuclein. So it took really like years and years and decades to identify the first gene that really like causes monogenetic Parkinson's disease. Up until then, it was really believed that it was an environmental disease. It can be quite intoxicating to look into the literature about genes and Parkinson's disease, but so far it is really about 11 or 12 genes that are really confirmed to cause monogenetic Parkinson's disease. What that means is that they need to co-segregate, so the gene defect the mutation needs to co-segregate with the disease in a family, in a particular family, and then you also need to replicate these findings in other families and hopefully also by other mutations as well. So 11 genes. There's a little bit of controversy whether the Gaucher disease gene should be on this list or not, but these genes, 11 or 12 in total, cause monogenetic Parkinson's disease. Most of them are autosomal recessive, and the others 3 are autosomal dominant. And then there are lots of other loci that attribute an increased risk to developing Parkinson's disease at some point in time. And maybe this is a much easier graph to understand this. So basically, here you can see the frequency in the general population of certain variants, so from variants to really mutations, as they can be found in the population, and then the risk that these changes infer on a patient. So there is this group of very rare but very clear disease-causing gene mutations, then some very important risk factors, and then very common changes, variants in the population that increase your risk over time to develop Parkinson's disease. But on its own, they would not be able to somehow be able to cause the disease or make it penetrant. What you will notice is that, for example, LRRK2 is here as a major risk factor, but also here as a monogenetic disease, and I'll come to this in a little while. I thought I'd give you 2 examples of familial Parkinson disease genes. So LRRK2, this is the one gene that Michael J. Fox has been identified with or to cause his Parkinson disease syndrome. So LRRK2 mutations were discovered in 2004, and different LRRK2 variants and mutations cause PD, Parkinson's disease, associated with this gene. And you can see this is a really big gene or protein, and it has different functional domains, a kinase domain, a GTPase domain, and you have different mutations have been identified, or variants have been identified throughout this gene. And usually these ones here around the kinase domain, but also outside the kinase domain, are the ones that clearly cause disease. Others may be associated with a higher risk of developing Parkinson's disease. And what is also quite striking, in addition to LRRK2 mutations being the most important ones in terms of numbers, it is also quite variable depending on the ethnicity. So in British or in white European societies, about 1.6% of sporadic PD can be linked to certain variants in LRRK2, but this is incredibly much higher in, for example, people with Ashkenazi Jewish backgrounds, where 30% of LRRK, of 30% of the familial as well as the sporadic diseases can be attributed to changes in LRRK2, and also North African Arab Berbers have a high rate of LRRK2 mutations. So this is an example of an autosomal dominant Parkinsonian syndrome. What is also quite interesting is that you have this particular gene mutation here, the most common mutation, so the glycine to serine mutation at this location in the kinase domain. And basically, if you carry this mutation, the disease becomes more prominent or penetrant with age. So at the age of 60, patients who carry this particular LRRK2 mutation have a chance of 30% to show signs of Parkinson's disease, and this obviously increases with age. Then another gene that is associated, as an example, with autosomal recessive Parkinson's disease is Parkin. So pathogenic Parkin mutations were first described in 2003, and Parkin is a very interesting gene or protein because it is an E3 ligase, so it has a role in the ubiquitin proteasomal pathway. It is the second most common gene mutation in Parkinson's disease, and usually, phenotypically, it causes It causes early onset, or basically like if you have a patient with very early onset Parkinson's disease, there's a very high chance that this patient has Parkin mutations, and especially if there's a positive family of it. The phenotype, mainly it's like the earlier onset of the disease, but often they present with foot dystonia. They have usually normal cognition and olfaction, spelling mistake, and a very slow clinical disease course of progression. They usually have a very excellent response to levodopa, but they often have behavioral problems that can be even like pre-diagnosis and also like during the course of the disease. I thought I'd give you a case presentation of two brothers who we've seen in the neurogenetics department with Dr. Gaudi. So basically the older brother presented in 2006 with a tremor of his right hand and foot scuffing when he was 25 years of age. He also reported that he felt quite depressed and he had quite complex sleep behavior problems. Past medical history apart from this was unremarkable, and at the time when he was seen in the neurology department he was on fluoxetine for his depressive symptoms. His family history was unremarkable at this point in time. So in 2006 he had one younger brother who was fit and well, and his parents were not related. So neurological examination at the time when he first presented showed mild unilateral Parkinsonism, so he was a little bit slower, he may be a little bit rigid, so like a little bit increased tone. He had a striatal toe, so like a little bit of an abnormal posturing of his left toe. Then structural imaging was normal. Then obviously, like in young patients, you're always concerned about to miss Wilson's disease, so you always send off ceruloplasmin, copper studies, and then, when all of this was normal, he also did not have Kaiser-Fleischer rings. A DAT scan was ordered, and this confirmed that we were dealing with a Parkinsonian syndrome, and then genetic testing for the Parkin gene mutations, the one that I presented earlier as one of the very common gene mutations in early onset Parkinson's disease, revealed that he had compound heterozygous Parkin mutations. And then he was commenced on dopamine agonist treatment, rotilogene. This is the patch that Kathy mentioned earlier, and that had a fantastic response. But with time, over 7-8 months, he ran into quite sinister problems. And I have a very nice video of him basically describing his symptoms at a time when basically his rotilogene dose was already reduced, and when he was behind all this what we called dopamine dysregulation syndrome. I hope the video works. Oh, it's too sad. So basically, what he's telling is, so this is at the time when he was basically already discharged, but he actually had to be brought into our ward because he was craving the medication. He managed to somehow bring his GP and us to prescribe lots of patches. He basically made excuses, said well, I'm taking a shower, I'm sweating so much, so I need more patches because somehow the patches come off, and then I need a new patch. I think his prescribed medication was 4 milligrams per 24 hours, but at the time of most of his symptoms, it was really he took 16 to 20 milligrams per day, and he was really what Kathy was describing earlier. He was really troubling his partner because he had this increased sexual drive, which is really not nice anymore. He was pacing around. He was going to B&Q at 4 o'clock in the morning. He was painting his walls, doing DIY. So it's really this very obsessive compulsive behavior. And he was not able to somehow decrease the medication at home. He really had to come into the hospital for a few weeks to really make sure that he decreases his medication. So he's been, over the last few years, he's been quite well controlled on levodopa, so we are staying away from a dopa agonist with him. And this is also a very good example where Kathy's role comes in, because she's in constant contact with this particular patient and the family, and so basically preempting any problems that he might run into the future, because he's only in his early 30s, so he has a very long way to go with his disease. So then a few weeks ago, his brother was actually referred to the neurogenetics clinic, to Dr. Gaudi and myself, and the brother reported symptoms or concern that he thought that he might also suffer from Parkinson's disease. What he told us was mainly at that time that occasionally, like, his left foot or his left leg was tremulous, and mainly he reported like low mood, anxiety, and also like very complex sleep disorders, where he was like hitting his girlfriend and like really like very violent sleep behaviors, for which he had actually been referred to our sleep clinic in neurology. Past medical history in his case was unremarkable, and the family history now obviously that his older brother had been diagnosed at the age of 25 with Parkinson's disease, and he has one healthy young daughter, I think like 2 or 3 years of age. So main symptoms were really that he reported anxiety, but on neurological examination, I couldn't help myself to really determine that he had a little bit of bradykinesia on the left-hand side, and most remarkably, postural stability. When you do the pull test, he really was walking backwards, so he was really quite unstable. And then we arranged for Parkinson gene mutation testing, because obviously he has a 1 in 4 chance to also be heterozygous compound positive for these mutations, and that was unfortunately the case in him. At the moment, we are mainly managing his depressive symptoms, and he doesn't really need anything as yet for his motor symptoms, but that might come with time. So why do we even bother about rare genetic forms of Parkinson's disease? I think I did my PhD on FBOX7, this is the Parkinson disease-causing gene, and I think at the time when I started in 2009, there were 3 families who were identified with FBOX7 positive disease, and I think even to date, maybe a total of 20 patients worldwide. At the time when I started my PhD, my supervisor suggested I should travel to Iran, to this really remote village, and seek these patients out to get skin fibroblasts. Well, I thought that was not such a good idea. So for patients, in very selected cases, it can really help to make a very accurate diagnosis and also help with genetic counseling. But I think it is very, very important. I come back to this slide in a second. When you think about, what I told you before, by the time these patients become symptomatic in terms of motor symptoms, quite a lot of their brain cells have already died, and not just dopaminergic neurons, but also other, it's multi-system neurodegenerative disease have basically died. So basically, at the moment, we are really only treating symptoms, but what we would like to understand is, because these rare genetic forms of Parkinson's disease share a lot of phenomenology and hopefully also pathways with idiopathic Parkinson's disease. So hopefully, if we know which gene to study, that this gene is implicated in the pathway of causing Parkinson's disease, then we might be able to somehow identify disease biomarkers earlier, and then also disease-causing treatments rather than symptomatic treatments. What I would also like to somehow point out is that there's quite a lot of research going on in Dundee, mainly at the College of Life Sciences in the MRC protein phosphorylation and ubiquitination unit, where I also did my PhD. This is the director of our unit, Professor Dario Alessi. And then these are just a number of people who are principal investigators at this unit who are interested in Parkinson's disease. So, and one of them is Miratil Mukit, who's also an honorary consultant in neurology. And basically, in the protein phosphorylation and ubiquitination unit in Dundee, the main focus is on protein phosphorylation and on ubiquitination, which are post-translational modifications of protein, and really important, very important in all intracellular signaling pathways. And for this unit, it is really important that maybe you have a monogenetic path towards the pathway. So then, it is important that there is potential of trackability of this pathway, and this is the case certainly with phosphorylation and ubiquitination. And then, basically, these are the points that determine whether a certain project is studied in the lab. And at the moment in Dundee, LRRK2, PINK1, Parkin, and FBOX7 is studied in the unit, and obviously in combination with industry and partnerships. The aim is really to make a difference to these patients and develop disease-modifying therapies. So this is it.
Right, according to the time, according to Apple, it is 2 o'clock bang on. So I'm not going to ask for any questions because we've all got to go. It's 2:00. Thank you very much for a really interesting set of talks. Next week we're going to hear about preoperative anemia from the anaesthetic department. They don't often get here, the anaesthetists, because they have their own departmental meeting at 1:00 on a Thursday. I'm promised that they're all going to come. So if you want to see a bunch of people in pyjamas, they're going to be here next week. So thanks again to the MFE department and to S from Neurology, and thank you to all of you for coming. We'll see you next week.